Hello, everyone. I'm Cheryl Peterson. Thank you for joining us for today's clinical Q&A for COVID-19. We're so excited to be here today to answer a few questions from our staff. I'm joined today by Dr. Mark Mazaid, who represents infectious disease, Dr. Deepa Murali, who represents our hospitalist group, and Stan Davis, our Chief Operating Officer. So we're ready to turn it over to Dr. Mazaid, who will give us a little overview on what's going on in the community with COVID-19.
So just as a brief review, COVID is a SARS-like coronavirus that was first described in China in the end of 2019, spread from China outward, and is spread by respiratory droplet and can be aerosolized with certain procedures that are done in the medical center. There are various predictions as to how it will impact our community here. The predictions from the epidemiologists that are working on this nationally anticipate a Texas surge around May 6th or so, but that may not necessarily be predictive of what happens locally for us. It could be for that. It might be that we've already had it. It might be that it comes later. But I think it's crucially important that we continue to be vigilant in what we're doing, that we be tactical in how we employ our use of face masks. We had our infectious diseases journal club this morning, and we reviewed a perspective paper from the New England Journal of Medicine that was describing what the type of decisions that physicians were having to face in ethical committees in Italy in determining who to ventilate and who not to ventilate, understanding that the decisions that they were making regarding who not to ventilate were basically allowing those people to die. And we need to understand that what we're seeing in our community now and what the predictions are could change based on one person who is a highly infectious transmitting person in our community that goes around and spreads the virus by not abiding by the recommendations, and that could change the whole perspective of any city in our country. The whole outlook. So, but I feel like we are making good strides in being prepared. I feel like the PPE recommendations that the CDC has made are appropriate. I've been exposed to TB patients even during the height of the AIDS epidemic in the 1990s and early 2000s, and worn my N95 mask, and I never have converted my PPE skin test. So I feel very comfortable about it. I have my mask fit testing when required, and I feel like the mask does a good job of keeping me safe. I feel like the N95 mask is not necessary when not using aerosolizing when not involved in aerosolized procedures. But I think that there is, even if with all this mathematical modeling, what really comes to pass is no one really can anticipate at this point.
The staff that are in the room with me will step into the screen to ask their question and then step out so we can maintain some social distancing. We also have staff joining us via Zoom. So let's take it away.
We work with an abundance of supplies. In the ICU, my isolation cart, outside of our N95 mask and the COVID-specific eye protection and that sort of thing, I always have an abundance of gowns. I have 3 boxes of gloves of every size, and it's really hard for me to rationalize as a bedside nurse that we are in a shortage, and I know that that's coming. from what we see in other parts of the world and other parts of the country. I've also been referencing the CDC's website related to, they have something called contingency and crisis measures, and it really looked like we were following all of the contingency measures, and that was really confirming to see that we weren't just making this stuff up as we go along. But I have a couple, I've also been in a position where I've had to negotiate, it felt like, with my charge nurse for the COVID specific protection wear, and that's kind of made me feel like a little bit of a criminal in that sense. But I think having a visualization of where we truly are as an organization would be helpful to staff to be better stewards. And then also, what can we expect as far as supply chain changes nationally that might impact if we can just get through an initial hump? Will we expect to have more solid supplies as we peak in Texas?
All right. Well, Rachel, thank you for the question, and also your caring and commitment towards the organization and the kids that you take care of each and every day. In regards to personal protective equipment, we do, as you've acknowledged, follow the CDC's recommendation on the appropriate wear and utilization of personal protective equipment. Our infectious disease and our infection control consultants guide us on that each and every day. So we set up those requirements to protect you and all of your coworkers in regards to making sure you have the appropriate PPE requirements in place so that you don't have to wonder. They're outlining. We do follow those CDC recommendations. In regards to our supply, we are fortunate in very good shape overall with all of our personal protective equipment. As you know, and we all know, we're preparing for the unknown in regards to the surge capacity. We're not as in bad a shape as places like New York, who are undergoing a tremendous amount of capacity with a patient load right now, but we're ready for, if that does occur, that we're going to be prepared. So as a result of that, we instituted a policy of having at least 60 days of PPE, gloves, goggles, masks and gowns, pampers, goggles, whatever it may be, in place to allow for us to have a daily usage and also to plan for how long that usage would allow with our supply and allocation streams. So we're not in the negotiation phase for any PPE. We're in great shape, but what we're trying to do is be better managers of our utilization of PPE. So everything that you need to protect yourself is available. We're trying to make sure there's no overabundance of ordering in this, and we might have too much in one location and not enough in another. So you'll see some more stringent measures in regards to getting things if they're above your allocation. So your allocation is what we determine to be your normal daily use, and those are being supplied. If for some reason there's a need outside of that, we would like for you to have a conversation with your charge nurse or your manager and our supply chain, because we do have it, but we want to manage it. So it's not negotiating, it's making sure that we have the appropriate usage. But if there's something beyond our allocations that need to be taken care of, we do have means to do that.
So Dr. Morelli, I know that you can speak directly to things that we've changed on the med-surg floors that I think are really powerful. If you want to tell us about that and what we're doing for staff to better protect them from the possible risk of exposure, because we can't test everyone at this time.
Mm-hmm. So yes, thank you for that question. It does sometimes feel to both nursing staff as well as to providers that life has changed in the hospital, that we're taking care of patients differently. But we're all here every day to serve Cook's mission of taking care of our patients to the utmost of our abilities and holding every child's life sacred. That being said, yes, life has changed. You know, COVID-19 is here, and we have made some changes in order to take care of both COVID positive / suspected patients as well as all our patients a little bit differently in order to both save PPE, decrease our exposure, and keep everyone safe. Having said that, things that you might notice are certainly on the floor, and I know you come from an ICU perspective, so this is a little bit different, but from a floor standpoint, you know, we're having less people go into COVID suspected / positive patients' rooms, so that might feel like care is being offered a little differently. More consults, as well as what used to be direct patient care is now being conducted over the phone. I know from a nursing care standpoint, some of the previously done kind of frequently in and out of rooms is now being bundled into kind of one visit. However, having said all that, the care of the patient and the way that we treat the patient is still the same. So all that is just to decrease exposure both for staff as well as PPE. But the care of the actual patient and the treatment of the patient is still the same. So if staff notice anything that they feel is being done truly differently, that patient care is being compromised, or that the treatment of the patient is truly not what they expect it should be, certainly speak up. There is a chain of command that you can follow from a nursing standpoint, as well as, there's lots of discussion and things are ever changing, both from a provider standpoint as well. So there's lots of discussion that constantly happens, but by all means speak up if you feel like a patient is truly not being cared for the way that is expected.
Related to that, my understanding is that Linda Thompson, one of our ICU physicians, was unable to be here with us. I have some ICU specific follow-up questions that I think I'll ask her because that was really the heart of my original email. And I know that we always are empowered at Cook to ask questions about care, and my main concern was that either there was something I didn't know as a newer ICU nurse related to COVID patients and their pathology, and that was why we may not be doing things, or it may appear that we weren't doing things that we might have done for just like a normal pneumonia, very severe pneumonia case. So I'll follow up with her, but I know that Cheryl and I spoke previously, and I think it would be really good for staff to hear from you as well, that you empower us to ask questions in the ICU setting when we're concerned.
Yeah, absolutely. I think that's part of our collaboration in care, is to have our voice, to raise our questions, use SBAR when we need to, so that we understand and we are all in agreement in what the plan of care is. Because sometimes that evolves very quickly, and I think we have to take a moment, stop, and ask those questions as they come up. So I applaud you for those thoughts and sharing those with us. Thank you.
Thank you for your time.
My question is for Dr. Mazaid. Lately, our anesthesiologists are treating all patients as if they have coronavirus, going full aerosol precautions, impermeable suit, goggles, N95, face shield. They say everything they do is an aerosolized procedure. Much of what I do as a respiratory therapist is an aerosolized procedure, creates aerosol anyway. Should we be wearing the full aerosol precautions gear? It seems like they're getting a little more protective of themselves. Is that something I should be concerned about?
That is a great question, and the answer to your question is we, as infection prevention folks, are not recommending anything other than the CDC is recommending, which is the N95 mask. If you want to reuse the N95 mask, and you should, you can put a standard mask over that and wear gowns and gloves. And anything that the anesthesiologists are doing above and beyond that is coming from their peer reviews of their experiences throughout the world. We're not recommending anything more than that. I looked last night at what the Society of Critical Care Medicine is recommending, and they're not recommending anything different than the CDC is recommending either.
For the masks, as a float team therapist, most of us in the hospital float from unit to unit, including taking care of 3 PAV patients and the 2 North patients that are either confirmed or suspected. As we travel around the hospital, should we be wearing a surgical mask to prevent the asymptomatic spread of this virus?
Yeah, that's a really tough question because I know it feels intuitive to wear a mask, but our guidance has not been that we need to wear that mask in our daily practice, in our daily maneuverings through the organization. That may change. And in the course of a day, we hope that we don't have staff going from those NICU units with those NICU preemie babies to the PUI units, the 3 Pavilion isolation unit, the 2 North isolation unit. That would be our best guidance, is not to cross those paths with patient care. But if we follow the guidance for PPE, and I can't emphasize enough the things you've already heard, but that environmental hygiene, cleaning those touch surfaces, I don't know that we've said it today, cleaning our phones, cleaning the things we touch every day, keys and those things. It is well worth the time to disinfect and wipe down our phones, our keyboards at home, and just help reduce that bacterial and viral load on any of that we could transmit. And that will be the best way to keep us safe and to keep our patients safe.
So between shifts, Sam and PI 2 North one night, one day, cleaning everything I have, cleaning my shoes and whatnot. The next day, going by the precautions, next day, next shift, whatever, I should be able to go to CICU
We
and ICU.
believe that, yes. If you are healthy and fever-free.
That's right. Getting checked. I can't sneak in this place without getting temperature
No, you
checked.
cannot. You cannot. Thank you.
The news coverage and all the media outlets are showing other hospitals in full head-to-toe gear, bodysuits. So to some people, it feels like those hospitals know something that we don't know. Should we be wearing those suits, especially in the 2 North unit and 3P?
There is nothing in the literature that I have seen so far, and no formal recommendations for anything other than the CDC recommended PPE. The things that are coming out in television reports are that those are facilities doing their own things. I feel comfortable about what the recommendations are.
Thank you. And my next question is for Dr. Murali. Several of us in the ICU have taken care of newly admitted patients who become COVID suspected patients after the 24 hours. Is there a way to limit unnecessary exposure? Is there a way should we be putting everyone in COVID precautions for the first 24 hours? What is your thinking on that one?
So
You sort of touched on it already.
yeah, so that's a great question. It's not only in the ICU, it's also on the floor that we run into the situation. In fact, I just had a long discussion with Dr. Susie Woodworth about this very situation that came up yesterday. So it's happening often. The truth of the matter is as Dr. Mrzaid alluded to, the CDC has come up with PPE guidelines, which we're following. And Texas and certainly Cooks has not seen the peak of our surge as yet. So it's a fine balance that it's a balancing act between having enough PPE to make sure that we have a good stockpile when the surge hits, as well as protecting our staff to the utmost of our abilities. There's constant discussion, I'll tell you, that happens on a daily basis as to whether masking everyone is worthwhile and what it'll do to our PPE supply. Some of the measures that we've instituted to try and prevent this on the floor, which I know is a little bit different to the ICU setting, is when patients are being admitted from the ER, is we do another triage system where a floor provider, whether it be an APP or a physician, will actually take report from the ER provider, but then we will also call into the patient's room and do our own triage system to see if the patient needs to be tested, and if so, they get to be on 3P with staff wearing appropriate PPE from the get-go. But truly, it's a matter that's discussed daily and will probably change daily. So.
Okay, thank you.
Hello everyone, my name is Mark. I'm also a nurse in the PICU. I have a couple of questions for Dr. Mrzaid. The first one it's about PPE, as you would expect. It's a lot of us concerned that most physicians or all physicians are wearing a lot of PPE, and yet the other nurses or care workers on the floor don't need the same coverage. So it feels like they know something the rest of us don't. If you're able to highlight on that question. And the second question that is really related to it concerns parents asking us to wear masks when we go into the rooms to see their children, even if they're not in isolation. And the question is, what should we say to these families?
Well, in response to the second question, I would accommodate a parent's request for that if it's not a big big deal. I don't think we're at such a crunch right now that if a parent asked for us to do that we should force ourselves in there without a mask. And in response to the first question, I don't know anything that would recommend that we change or upgrade the PPE to Ebola level PPE. I don't know anything. I'm not hiding anything new. There isn't any other information out there. These are people that are working in high incidence areas who have escalated that based on their own concerns, but not because of something in the literature or something that's going around that hasn't been made widely available.
You know, Mark, to answer that question also, I think reminding our families and our visitors that our staff are screened every day when they come to work, and that we have educated our teams about what symptoms to look for and ask them not to report to work if they are ill. So I think that guidance may be helpful so the visitors and parents don't think that it doesn't apply to our staff.
Thank you.
Thank you for letting us ask these questions. This one goes to Stan. Are we soliciting for homemade PPE because we're close to running out? And how will we know that homemade options are really effective against the coronavirus?
First, no, we're not close to running out of any of our PPE. We have adequate quantities. Like I said earlier, if you heard me, we are looking at a 60-day allocation for all of our vital PPEs. The only areas, I'll be transparent with you, that we're not at 60 days right now are gloves. We're still in good shape, but we're not at the 60-day point. Head covers, wipes, hand sanitizers, and Pampers. But working with our supply chain, and also I'll tell you a little bit about other supply efforts that we're getting in, we're trying to meet those levels. So our supply chain has relationship with vendors, and we're sourcing all different types of options right now to restock or to replenish our current supply, as well as we're receiving allocations from our RAC, our Regional Advisory Council, in regards to requests that we've been having. So there's a current effort to make sure that we meet those 60-day allocations that allow for our daily usage to be maintained for a 60-day period. So for handmade masks, what we are doing right now is allowing for, in addition to folks in the communities, our home health department to make homemade cloth masks with specifications that we have described. And the reason we're doing this is to allow for that option for primarily our families to be, who are families of patients who are non-suspected or non-positive COVID patients, to be able to be given a mask that does not take away from our surgical mask capabilities here. So we're in the process right now of collecting those homemade masks that are to meet our specifications, with oversight from our infection control and infectious disease specialists in regards to the requirements for them. And at some point in the future, we will start providing those masks to family members who desire them to come in and be in the facility. That's not because we're short. That is because we want to make sure that we protect the supply of surgical masks that we have for our caregivers, and that we can meet that surge that we talked about if it does occur here in the area, that we'll have an increased quantity to meet the needs as the CDC recommendations evolve, or as things evolve in regards to protecting our families and our patients.
For you, Cheryl, again, thank you guys on the command center for, I can only imagine that you're dealing with the whole Metroplex and regionally all the information. So we have heard some rumors that we'll be taking care of adult COVID patients. Is this true? If so, I feel like many of us don't feel prepared for that.
Well, that is an interesting question. We've seen such high volumes of patients in some of those hot zones, hot spots right now throughout the nation and the world. We have carefully considered what our surge capacity might look like at Cook Children's. And following the guidance of Children's Hospital Association, we feel like our mission is for children, and that all children in our region should come here for their care, which would allow capacity at other hospitals. In North Texas, there probably aren't very many hospitals. We and a few of our other children's partners are the source for care for children. So we don't know what that opportunity is, but in those communities that have a higher condensed population, that does happen with a number of hospitals or pediatric units. So we would encourage our partners in the community, other hospitals, to send their children to us first, and we've selected that as our first tier of patients that we would accommodate, and that includes neonates. So we would be very happy to take those newborn or adult patients. Our second choice would be to consider adjusting our age of patients. So as you know, we take children and young adults up to the age 21. And so we would consider expanding that age to 25. Our physician partners have agreed to that as a second tier, and we would look at those populations of patients that we care for. So we see congenital heart, we see some epilepsy and neurology patients, we see pulmonary with some cystic fibrosis patients. So we feel like that would be in our wheelhouse, in our comfort zone. We also recognize that we have an age limit for trauma victims up to age 14. We have talked with our surgeons as well as the Regional Advisory Council here in North Texas about extending that age to 18. We have talked to the local level 1 trauma centers, and we think there is receptiveness to allow us to do that in some cases. There may be a few patients that wouldn't fit here very well. Some of the orthopedic pelvic injuries might not be a good population here. So our preference would be to take well patients and patients whose diagnoses we are comfortable with.
And if I could add to Cheryl's thoughts on that, hopefully what we see here is we're learning from elsewhere where these events have occurred, and China and in Italy and possibly even New York. What we're seeing is because of this collaboration not occurring in advance like we're doing now, many adult hospitals are looking at just shifting that burden to the Children's Hospital. So we're trying to plan through our Children's Hospital Association, through our RAC, through our CEO communications that happen every day, the efforts that Cheryl just mentioned, and so that we can look at it from a proactive perspective as opposed to just reacting to a surge. So I hope we can appreciate from the perspective we are the guardians of the health of children in our region, and the community respects that, and they're looking to us to say how best to continue to maintain that.
I think another thought in addition would be for us to appeal to our nursing staff and to our other clinical staff that if we do receive a surge, whether it be our pediatric patients or young adult patients, that we may need more staff to help on our floors and in our ICU. So if you are a nurse or a respiratory therapist or a PCT, someone that feels like they have the interest and skills, this is the time for you to come forward to us and to your leaders so that we can try our very best to get you the training and education that you need so you can come and make a difference should we receive that surge. We have worked very closely with the Professional Development Council, which is our educators, to help us to identify some curriculum that we can put in place very quickly. The best that we can do is to prepare our staff. And so at this time where we have what I will call a lull, we're waiting for that tsunami and trying to determine what that wave will be here. This is the time to do it. 2 weeks, 3 weeks will be too late. I'd like to thank all of my colleagues for joining us today, for the great questions from the clinical staff to my professional colleagues, the physicians and Stan, and to our staff. Thank you all so much for everything you do. We cannot say it enough from our hearts that we appreciate you, we care about you, and we're here for you. So thank you for joining us today, and we hope you enjoy this educational video. Thank you.